Thank you so much, Dr. Shah, and thank you, Desi ji and Vijay ji, for this wonderful opportunity. This is just a great platform to educate about the importance of sleep. So in this presentation, I will discuss some of the common sleep disorders that exist and what to look for in those disorders and some of the symptoms and signs associated with it. If I'm going to start off with what we call as obstructive sleep apnea. So what is obstructive sleep apnea? It's a condition when there is a repetitive collapse of the upper airway when somebody is sleeping. Now, this collapse could lead to complete stop of the airflow for 10 seconds that we call apneas, or it could be a partial airway collapse that we call hypopnea. So you could see here that this person airway is open, whereas here the airway is tend to close while they are sleeping. And this is what we call obstructive sleep apnea. And these episodes keep occurring on a recurrent basis throughout the night. So in terms of how common is sleep apnea, it is actually a very common condition, but unfortunately, it still remains under-recognized and undertreated. So it has been shown that at least 80% of the men and 90% of the women still remain underdiagnosed and undertreated. But there have been different studies looking at the prevalence of obstructive sleep apnea, and it has been ranged anywhere from about 9% in women to about 24% in men. It's more common in men before the menopause, but after when the menopause hits, the prevalence is very similar amongst both genders. I want to highlight that the prevalence of obstructive sleep apnea is also more in those who have some heart conditions. The prevalence of sleep apnea in those with hypertension could be as high as 83%. And there are some studies to even suggest that obstructive sleep apnea could cause high blood pressure. So more data is out there out of all the cardiovascular diseases with the obstructive sleep apnea and hypertension, that it is very prevalent in those cases. And it can also be one of the leading factors for hypertension. It is also very common in those who have heart failure, those who have arrhythmias, those who have stroke, and any heart condition such as coronary artery disease. So some of the other comorbid conditions that could be associated with obstructive sleep apnea are stroke, heart attacks, high blood pressure, like I said, even high cholesterol. Diabetes is also very common in these patients. Atrial fibrillation, the arrhythmias, the irregular heartbeats are very common in these patients. Heart failure is very common in these patients, and depression is very common in these patients as well. So what are some of the common symptoms of obstructive sleep apnea? The symptoms of obstructive sleep apnea could be divided into nighttime symptoms and daytime symptoms. So in terms of the nighttime symptoms, snoring is one of the most common symptom, and especially the loud snoring is associated with obstructive sleep apnea. However, absence of snoring does not mean that you don't have sleep apnea. Gasping for air, witnessed apneas, which means somebody observing having pauses in breathing in you, is actually a very sensitive sign for having obstructive sleep apnea. These patients may also have trouble maintaining sleep. They tend to wake up because of these recurrent episodes of stopping or not breathing. Nocturia, tending to go to the bathroom a lot in the middle of the night, it could actually be a symptom of obstructive sleep apnea. So obstructive sleep apnea causes a lot of stress in the heart, which releases this hormone, which leads to go to the bathroom a lot in the middle of the night. And we have seen in our clinical experience when we treat patients with obstructive sleep apnea, the nocturia or the tendency to use bathroom in the middle of the night gets better. They may also have night sweats. And very commonly during the day, we see that these patients are excessively tired, they are excessively sleepy, they are fatigued, they may have drowsy driving because their quality of sleep is disrupted. They had unrefreshing sleep, they may have morning headaches, and that is because the obstructive sleep apnea is linked with oxygen levels going down with these recurrent episodes, but it is also linked with carbon dioxide levels going up. So when the carbon dioxide levels go up in the morning, it can lead to morning headaches, impairment in memory, impairment in concentration, irritability, and decreased libido. So what are some of the risk factors for obstructive sleep apnea? Weight is a one big risk factor. So we have divided the risk factors as modifiable and non-modifiable. Modifiable is something you could change. Non-modifiable are things that you cannot change. So in terms of something that you could change, like I said, weight is one big factor that we have some control over it. And it can lead to increased neck size that can be a risk for obstructive sleep apnea. It also changes the anatomy inside. Certain medications are at risk factors. Somebody who is on opioids or benzodiazepines, alcohol is a risk factor for obstructive sleep apnea. Somebody who has some endocrine disorders like thyroid problems or polycystic ovarian disease is a risk factor. Smoking itself could be a risk factor for sleep apnea because it tends to relax the airway. Nasal congestion or obstruction, having a lot of congestion in the nose could be a risk factor. Some of the things that we cannot change, non-modifiable risk factors, like I said before, males are more predisposed to have obstructive sleep apnea compared to females. And like every medical disorder in the medicine, this also have genetic predisposition. It has its hereditary genetic factors. So having a family history of sleep apnea could also be a risk factors. Ethnicities, blacks are more likely to have sleep apnea. But Indians are also more likely to have sleep apnea, and that is because of their craniofacial anatomy. They tend to have very narrow airway inside, and these are some of the things that we cannot change. Aging is a risk factor. So as we age, like Dr. Shah mentioned, the sleep quality is disrupted. Also, the risk of sleep apnea increases because the airway sort of becomes more loose and more collapsible. So it is going to, it would have more tendency to sort of collapse more. Menopause. So after menopause, the risk of sleep apnea increases tremendously in women. So I want to highlight the sleep studies. The only way to diagnose somebody with sleep apnea is to do a sleep study. We do require sleep studies to diagnose somebody with sleep apnea. And just so you know, there are two kinds of sleep study out there. One is the lab-based study where one would go and spend a night in the lab. They are hooked up with lots of monitors around the head, chest belt, belly belt, and we see if they have sleep apnea. If they do, how bad it is. But now the recent concept is about the home sleep apnea testing, where we could ship the equipment to you, and there are instructions in there, and one could use those equipment yourself, and you would sort of ship it back the next day, and we can then determine sleep apnea based on the home sleep study as well. But we require sleep study to diagnose for sleep apnea. This is sort of a little technical slide. All I want to say is that in order for us to diagnose somebody for sleep apnea, we need a sleep study, either a lab-based study or a home-based study, and we need to see those episodes that I was describing, either complete cessation of airflow for 10 seconds, that's called apneas, or decrease in the airflow, what we call hypopneas. We have to have a combination of both, and if it is happening more than 5 times an hour, there is sleep apnea, and we characterize the severity of sleep apnea based on this metric. So if it is 5 to 15, it's mild sleep apnea, 15 to 30 is moderate sleep apnea, and over 30 is severe sleep apnea. So what about the treatment of sleep apnea? So good news about sleep apnea is that it could be treated. And the positive airway pressure, what we say, or CPAP or AutoPAP or BiPAP is a gold standard treatment for obstructive sleep apnea. They are conservative measures, and I'm going to discuss a little bit about it. There is oral appliances like a mouthpiece, which is out there, which can help with sleep apnea. There are some expiratory positive airway pressure devices, which can help. Surgeries, there are all kinds of surgeries out there, minor surgeries, and major surgeries, which would help with sleep apnea. And a newer modality out there is this sort of implantable pacemaker, sort of a device, which can stimulate your tongue and prevent it from falling backwards. So, like I said, the CPAP machine, the positive airway pressure, is the gold standard for sleep apnea. So you see here, uh, this person had sleep apnea, but when the positive airway pressure is implemented, the airway is opening. So it sort of acts as a splint, and it splint open the airway when it is introduced on the patient. There are many kinds of PAP therapy out there. It's a continuous positive airway pressure therapy, which is sort of blowing in the air continuously. There's a newer therapies out there, which is called auto CPAP, where we can give sort of this pressure range instead of a fixed pressure of CPAP, where the machine can adjust itself depending on the sleep apnea. Some people tend to have sleep apnea worse on their back. You know, the snoring is worse on their back, and this auto PAP could adjust the pressures. It can probably give higher pressures on the back. It can give higher pressure during the dream sleep. You know, the sleep apnea tends to be worse in the dream sleep as well, because the airway sort of gets paralyzed during the dream sleep, and so there is more tendency for airway to collapse. The auto PAP machine has the ability to adjust itself. The BiPAP machine, some patients cannot tolerate the CPAP, and then we have to give them BiPAP machine, which is more comfortable to them. You could see here, these are sort of different PAP therapies and different interfaces out there. There are different kinds of masks. You know, there's a full face mask, which covers your nose and mouth. There's a nasal mask, which covers your nose. And then there's a nasal pillows, you know, right here, which can sort of sits on your nostrils. This is more of a hybrid mask, which sort of acts, which is blowing air through the nose as well as through the mouth. And this is this CPAP machine. Now, there are a lot of benefits of PAP therapy. One important benefit, which has been shown, and we have also shown it at Cleveland Clinic with our cohort, that it can improve the blood pressure in those patients who have elevated blood pressures. It has also been shown to have lower the risk of atrial fibrillation, may improve ejection fraction in those with heart failure, and may have some effects, positive effects on cardiovascular events. But in terms of all of them, and then if we have to compare the greatest benefit in the medical field has been shown with reduction in blood pressures, whereas other benefits are yet to be shown in the prospective sort of randomized controlled trial studies. In terms of daytime improvement, a lot of evidence out there, and we have shown the same. It improves the quality of life. People feel better, the daytime sleepiness is improved, the fatigue is improved. We have shown that there are better quality of life scores. Even the cognitive functioning is improved because the sleep gets consolidated. And then it has also been shown to improve the motor vehicle accidents. I also mentioned conservative measures for sleep apnea. I said weight is one of the greatest modifiable risk factors. So weight loss could also help with obstructive sleep apnea. 5 kilogram reduction in weight could reduce that number that I was telling you, apnea hypopnea index, by 2. Positional therapy, like I said, some folks may have sleep apnea worse on their back. So avoiding sleeping on the back, there are certain belts out there which can prevent rolling you over the back. Some of the traditional therapy is that we ask people to sew those tennis balls at the back of the t-shirts to prevent them going over their back. That could be helpful for somebody who has positional sleep apnea. Avoidance of alcohol, avoidance of certain medicines like benzodiazepines and opioids, because they have the tendency to relax the airway and thereby promote obstructive sleep apnea. And then treatment of allergies, somebody who has nasal congestion, treating it with nasal steroids could also help with obstructive sleep apnea. So like I mentioned, CPAP is still the main treatment out there, but some people may have trouble tolerating it. And there are other treatment modalities, what we say mouthpiece or oral appliance. Oral appliance is something which sort of goes in your mouth, and the idea is that it is going to push your jaw forward, sort of create more space at the back of the throat. These are different oral appliances out there. It is more effective in those who have sort of milder forms of sleep apnea, people who are not overweight. But in mild sleep apnea, it may be as effective as the CPAP therapy, but in moderate to severe sleep apnea, it may not be as effective. But when we see patients and if they're not able to use CPAP, I then tell them try oral appliance. It may be better than nothing. And given the deleterious effects that obstructive sleep apnea is associated with, I would still recommend treating it to any degree compared to not treating it at all. Like I mentioned, the hypoglossal nerve stimulator, which is sort of this implantable device. This is a newer therapy out there. You may have heard the commercial for this. This is this implant, which is implanted in the chest, and then inside it is stimulating the tongue, and it is preventing it from falling backwards. And the patients don't have to use any CPAP. They have this remote, which sort of they have to put this remote on top of that sensor, and then it turns on, and then it turns off automatically after 8 or 9 hours, whatever we set it at. And then throughout the night, it is sort of stimulating the tongue, and it is preventing it to fall backwards. Relatively new therapy, but have shown good results, especially in improving the quality of life. Now I'm going to shift gears and talk about hypersomnias or excessive daytime sleepiness. Just so you know, there are many hypersomnias conditions out there which are related to something pathological or bad brain. Of course, there could be something such as insufficient sleep or sleep deprivation that can cause excessive daytime sleepiness or hypersomnia. However, there is something that could happen pathologically, and these are the conditions which can cause you to be intrinsically sleepy. Not as common, but just be aware narcolepsy is out there. There's idiopathic hypersomnia. There are all sorts of hypersomnolence conditions which people may not have any control of. Narcolepsy, I just want you to be aware, is a condition mainly of adolescents, but often gets under recognized and undertreated. What like Dr. Shah was alluding to, if somebody over the age of 10 years is taking nap, that is sort of a red flag. And the red flag is probably they may have disorders of excessive sleepiness, such as narcolepsy. The cardinal feature for narcolepsy is these patients are excessively sleepy. They may have something called as cataplexy. They may feel weak. With any emotion, they may hallucinate while going to sleep, and they may feel that their body is paralyzed when they wake up. Just some of the things to be aware of. Insufficient sleep, Dr. Shah has already covered, but it is just so important. So I thought I'll just insert a couple of slides on this. This was one of the largest sleep study ever, where they had introduced the Fitbits on some of the patients and had shown what is the average amount of sleep an American is receiving. So it showed that the average amount of sleep somebody is receiving is about 6.5 hours, which is way less than what is recommended, which is 7 to 9 hours of sleep. And then showing you some averages bedtime and wake up times based on the different age groups. Generation Zs were shown to be sleeping around midnight and waking up around 8 o'clock. Millennials were shown to be sleeping at around 11:45 and waking up at 7:30, and so forth. Something happened. Okay. Sorry, something is going on. This was based on the Gallup survey, and then as you could see that the average sleep that an average American is receiving has reduced significantly over the course of years. And nowadays, 40% of the Americans are cutting their sleep short, and it's about 6.8 hours of sleep, which is way less than what we recommend to be 7 to 9 hours of sleep. Dr. Shaw already alluded to what's the normal amount of sleep that a person requires, and you can see it is divided based on the age groups. A normal adult requires about 7 to 9 hours of sleep. It's a recommended amount of sleep. It may be appropriate for some people to sleep for 10 hours. It may be appropriate for some people to sleep for 6 hours, but the average is 7 to 9 hours of sleep. And you could see that with increasing age, these are the newborns, infants, toddlers, preschool, school age, and so forth, that the sleep requirements is decreasing, and the recommended sleep requirement also decreases. And that is based on the physiological needs of the body. A few words about the circadian rhythm disorders. Dr. Shah already alluded to what circadian rhythm is. It's this normal sort of sleep-wake rhythm, which is governed by the extrinsic environmental factors, extrinsic cues such as light, as well as the internal clocks. So the circadian rhythm disorders occur when there is a misalignment between the person's sleep in a 24-hour period. It could be, like I said, changes in the light-dark cycle relative to the internal clock, or changes in the internal clock relative to the light-dark cycle, or there may be a dysfunction in the internal clock. Few words about delayed sleep phase syndrome, what we call it sort of night owl syndrome. This is more common in adolescents. These people have naturally the tendency to sleep late and wake up late, and that is just sort of naturally that can happen. The problem with this is that they are just not able to function based on the social norms. The society starts the day somewhat early, but their body is just not ready to wake up in the morning. So this is called delayed sleep phase syndrome. It could be treated by just changing some of those cues that we discussed, light and melatonin. It can be somewhat relatively fixed, but it could be common in adolescents. Advanced sleep phase syndrome, Dr. Shah already alluded to, could occur more so in older age groups. So this is like a morning lark sort of a syndrome where the tendency is to sleep early and wake up early. So what could be the implications? The implications is that these people may not be able to enjoy the late evening activities. They may want to go to bed a little early and wake up early. And there's nothing wrong with it if there's no problem for the patient. But if there's a problem for the patient, then only we treat any of these sleep disorders. Shift work disorders, it is because people are working different shifts. There is a misalignment in the circadian rhythm. It's an inability to sleep during sleep times and excessive daytime sleepiness during work hours. And we could sometimes treat it with the help of certain medications to help control these symptoms of trouble sleeping or excessive daytime sleepiness. I'm going to switch gears to something called as restless leg syndrome now, just so you be aware. What is restless leg syndrome? It's an urge to move the legs, particularly legs. It could be upper limb as well, such as arms, but it's an urge to move the legs, which gets better when we move them. And then it is worse during the evening hours. So restless legs can impair the quality of sleep. Many people have trouble falling asleep. It can occur on daily basis or at intermittent basis. Like I said, it is mainly affecting the legs. Sometimes it can affect the arms as well. It occurs in both the legs, but sometimes it can happen in either one leg or one arm, but it can involve the trunk, arms, especially later in the disease. And we sometimes look at the sleep study and we see these limb movements that are occurring in the sleep study, the in-lab study, but that is really not necessary for us to make the diagnosis. We diagnose somebody with restless leg syndrome just by history. We do not need sleep study to diagnose restless leg syndrome. It is very common. 5 to 10% of the US adults have it. And this is more common in women. And like every sleep disorder, this also occurs more with increasing age. And it can also happen in children, and oftentimes it can be misdiagnosed as growing pains. This can be easily treated. There are medications out there. And when we treat them with medications, patients often feel relief in their restless leg syndrome. and improvement in the quality of life. With this, I will end the presentation, and I will give it to Vijay.